not like your tutorial. Tutorial you only have MCQ, but for this session we have more case scenario, and of course we encourage you to participate more. Unmute yourself to talk if possible. Otherwise, I'm talking to myself very odd. Okay, and because I'm alone, so I need to see if you have anything, you better unmute yourself to talk, or else you can type at the chat box. But I need to spend some time to look at the chat box and control the site. A bit difficult. Prof. Fu is not around today. Okay, I'll be myself only. Okay, hope you bear with me lah. Okay, we have three parts here: hematology, oncology, and palliative care. Okay, we'll start with hematology first. Okay. Without any ado, let us start. Any question so far? No, okay. You can switch off your camera. Then we go to the case now. Let me share the slide first. Can you see the slide? Looks like not okay.
Yes, doctor. Yes, doctor.
Yes, doctor.
Yeah, no, sorry. Okay. Okay, what is the most common hematological problem in primary care?
Anemia. Iron deficiency anemia.
Anemia.
Yeah. Okay, good. So we're going to do some revision on this. We're going to go back to the basic to do history taking, physical examination, lab investigation and interpretation, and management. And always in primary care, we decide when to refer or admit the patient. Okay? So the first case, a 40-year-old lady present with tiredness. What further history would you like to elicit?
Morning, Prof. May I try first?
Can, no problem. Can you introduce yourself?
Yeah, I'm Kumuta here.
Hi,
Morning,
Kumuta. Hi.
everyone. Yeah.
Hi.
So this one, sorry, doctor.
I can hear you.
Okay, cool. So this one is a 40-year-old lady with tiredness. So first, the onset duration, and then associated symptoms. Because tiredness can be anything. It can be DM punya symptom, can be thyroid punya symptom, can be anemia, can be malignancy. So I'll ask all the question pertaining to that, keeping differential diagnosis in mind. So diabetes, we ask for polyuria, polydipsia, polyphagia, all that, and then family history of diabetes. And then for malignancy, constitutional symptoms with any breast lump, breast mass, because she's 40-year-old, bone pain, all that, and then family history of malignancy. And then hypothyroid punya symptoms, any constipation, any menstrual history as well, menorrhagia, all that, and then the anemic symptoms, other symptoms, chest pain, palpitation, SOB, failure symptoms. And then with that, after that, we go to the past medical history, any significant comorbid, any medication on board, and then past surgical history with any over-the-counter medication, traditional medication, or yeah. So after that, menstrual history. So because tiredness, so once with all the symptoms, then only we can make it out possible differential diagnosis, and then we proceed further with examination to check.
Examination later.
Examination later.
We'll go to that later. Okay. Good. Okay. You have mentioned about the history of presenting illness, right? First, and you ask about actually you already asked about the past medical history. Okay. We will stay at the past history of presenting illness first. Anybody else, history of presenting illness, what actually you want to ask? Anyone? Or you can type at the chat box. I try to look at it. Okay, yes, duration. Onset duration, yes. Do you have any mnemonic for this or acronym? Severity, yes. Yeah, you commonly we use Socrates. Okay, all charts, whatever. Okay, you can follow that lah for your history of presenting illness. Okay, then you have constitutional symptoms. Okay, good, you cover that. And history of uh, thyroid disease. Okay, so we ask further on the thyroid disease. So anyone thyroid disease and a 40-year-old lady with tiredness, what kind of thyroid disease you should have? It's more common, I mean. Yeah, hypothyroidism. So you mentioned menorrhagia and constipation. Any other symptoms of hypothyroidism you can elicit? Yeah, weight gain, cold intolerance, yes.
Depressed,
The
low.
replacement will come later. Yeah, good. Yes, hoarseness of voice is very important. Hoarseness of voice, yes. Okay. Okay, mood change. Now we go one by one. Mood change, what do you mean by mood change there? Mood changes. Maybe Kartini, can you elaborate a bit on mood
Can you hear
change?
me?
Yes.
Okay. Good morning, I'm Gantini here.
I,
Mood changes like low mood. Sometimes they feel like
yeah. Oh, Kartini?
lack of interest, depression kind of symptoms,
Yeah, depression
anxiety.
is important. So if we focus more on the depression, okay?
Yes.
So loss of interest, what do you call that?
Hedonia.
Yes.
Anhedonia.
Okay. And any other symptom of depression you want to ask?
Suicidal, is it?
Psychosis.
I'm not sure.
Severe.
Doctor.
Oh, psychosis is yes, is severe form now, okay?
Sleeping,
Severe
doctor.
sleeping
Sleep,
problem.
sleeping issues, insomnia.
Yes. What else? Okay, some
Suicidal, like
say
hopeless,
yeah,
worthless.
suicidal, hopeless, yes. Poor concentration. Rivati said poor concentration, yes. And one more symptom, quite relevant one. Memory issue, yes, of course. And one more symptom relevant to depression, which is quite important. Yes, feeling guilt.
Fatigue,
Yeah, feeling guilt.
guilt.
Okay. The rest you'll cover. Okay. Now you cover depression, hypothyroidism, and Kumota just now mentioned about the malignancy. Yes. So what particular malignancy you want to ask actually? Other than breast, common thing first. Leukemia, yes. But if you do the Prof. Course assignment, yeah, colon cancer. Yes, cervical cancer also. So is you can ask what symptom you want to ask if colorectal cancer, other than loss of appetite, loss of weight, or the constitution. Yeah, rectal bleeding, outer bowel habit. Yes. If cervical,
Postcoital bleeding, doctor.
yeah. Yes. Per-vaginal bleeding is good, but postcoital bleeding is more specific. Good, good. Okay, we go back to the general, the history taking. What other history you want to ask? And focus and just now Kumuta covered quite a lot. She mentioned about the medication history. What medication particularly you want to ask?
NSAID, aspirin,
Yes. Why?
it can cause peptic ulcer disease.
Then, yes. Then
And then,
further,
and then lead to occult bleeding and
yeah,
resulting in anemia.
yeah. So you cover it. Yeah, CKD, chronic kidney disease, you can put it under past medical history of chronic diseases. Okay. Okay, we'll go back to the general. What further history you would like to ask? Just now I saw one diet history. No Faham Nim. Diet history.
Yes,
Yeah.
but
Mm.
usually most of the patient come to clinic. We diagnose them with IDA lah after done
Okay.
investigation.
Iron deficiency anemia. Yeah.
Yeah, especially in Malaysian, poor diet in high iron content, especially kids dengan adult jugalah.
Okay. So which group particularly have prone to get iron deficiency anemia?
Vegan,
Yes, vegan. Okay. Okay. What other thing in diet also can contribute to iron deficiency anemia? Other than the vegan, vegetarian, anything during a breakfast? Just now I have taken something can cause anemia.
coffee, tea,
Yeah.
caffeine,
Why?
because they reduce the absorption of iron.
Good. Yes.
But we still drink coffee lah, doctor.
I don't have anemia. Haha. Okay. Okay. What other history? You have a template of history taking, right? So you go through the history of presenting illness, past medication, constitutional symptom, then diet history, menstrual history. Okay, menstrual history just focus. Okay, one by one. First, Chan Mei Yin, you mentioned about past surgical. So what kind of surgery you want to ask? Past surgical history.
Past surgical history,
Mm-hmm.
any history of peptic ulcer or any GI bleed before?
Okay, which undergone some surgery lah.
Yeah.
Okay. Menstrual history. Okay.
There's a possibility of premenopause symptoms or menopausal symptoms, or whether patient
Menopause. 40-year-old. Too early lah.
too early.
Okay. But menstrual history, just now Kumuta mentioned, but I think it need to be complete. When you assess menstrual history, so what all the things you want to ask usually?
Whether patient has very heavy menstrual bleeding.
Okay. How to assess that?
Ask about the how many days of menstrual each cycle.
Yeah, duration. Then
And how is the flow every day.
flow, yes. Further? Yeah, your friend mentioned blood clot, yes, which means heavy menses lah. Also, how many pads use? Very good. Okay. And of course, Nurul Huda, you mentioned about pregnancy. So how can you ask in history? Maybe you can ask whether you are pregnant or not. But of course, you need to ask the last menstrual period, right?
Yes, doctor. I will
So
ask the last menstrual period.
Yeah, that's important. Okay.
Yes, doctor.
Okay. Okay. We cover that. Any other history you want to ask? There are still few history you need to cover. Family history, very good. Dan Zihao.
Hi, doctor.
Hi.
I will ask family history regarding any thalassemia and then any inheritance possibility of CA lah, like colorectal CA and also
Good,
breast CA
good.
for this patient.
Yeah, very good. This is very relevant. Okay. Thalassemia is very relevant and it's common in Malaysia actually. Okay. And social history, last one before I think you cover most of it. Social history, anyone? Yeah, alcohol consumption. Yes. Job, okay. Hidayah, occupational job. So what kind of job actually contribute to tiredness other than doctor?
Sometimes we need to make sure that the shift, like staff nurse,
Yeah,
this.
shift job. That one very relevant. Okay. Yeah, teachers, yes. Drugs, Selvan, what do you mean by drugs?
Okay, for such cases, usually if the patient was an IVDU or having of ketum or any this kind of related on social problems.
Yeah, yeah. It's exposed to lah. Oh,
Ah,
okay. Oh, good, good, good. Even though 40-year-old lady, yeah, we still need to ask lah sometimes. Okay. Okay, of course, if you talk about drugs, one more important one, common one, you should ask. I don't think anybody answered yet. Alcohol, drugs, anything in between, you need to ask. Very last one. Yes, smoking. Smoking is more common. Okay, good. Anything want to add before I go to the next session? Okay, so these are all the symptoms you need to elicit history. Okay, OSA, yes, it will cause sleeping problem. Okay, this one, symptom anemia, PR bleeding, menses, diet, bowel habit, urine, constitution symptom, sleep, hobby. Okay, hobby also means that. Okay, anemia, family history, NSAID, drugs, particularly NSAID, smoke and drinks. Okay, for history taking, what is the purpose of history taking? We want to establish a diagnosis, exclude the differential diagnosis. If possible, we try to find out the cause of the presenting illness, the complication from the presenting illness, okay? And you want to elicit red flags. What is red flags? Because primary care is very wide, so you try to pick up something important so we won't cause problem. We won't miss anything important. So what is red flag? Anyone? Okay, severe anemia malignancy is red flag. What the red flag means here? Yeah, Kumota, you're right. All these are red flags. Anyone? It's important in primary care, right? Red flags. Okay, symptom that shouldn't miss is quite emergency. You need urgent attention. Yeah, urgent referral. Okay. So whatever you say, remember that, okay? It help you in your clinical practice also. Now we go to physical science. That's how Kumota want to continue from that, but let other people have a chance lah. Anyone? Okay.
Doctor, okay, can I?
Yes,
Okay. We can start from assessing general examination. We
good.
look for pallor,
Yes.
fatigue looking, and then cachexia. And then from general, we can have.
Wait. Rosanna, right?
Yeah,
Hi.
yeah.
Palo, where you want to look for palo?
Oh, sorry, conjunctiva, doctor.
Only conjunctiva?
We can see the palm also. We can see.
Yeah, palm. What else? Where else?
Um, um, you can see like nail bed. We can
Nail, yes, nail
uh,
bed.
lips, but lips more on and like stomatitis, angular stomatitis. We can see that lah, but
Yeah, lips. Actually, it's
lips,
mucosa lah, mucosa.
yeah, because someone lip.
One more place.
And then what is it? I think that's it. Somewhere anything.
Anyone want to help? Oral, yeah, continue oral.
Or
Which part of oral want to see? Other than mucosa, oral only one more thing. Tongue, yes.
Tongue,
Okay. Some people like to look at the sore also, meaning the plantar sore. If your patient have anemia and the plantar, meaning the anemia is very severe already. Okay, that's a extra knowledge lah. Okay. In the books only we examine palate up to tongue only. Okay. Okay. Rosanna, you want to continue on that?
um then we can continue examine the nails. There's signs of koilonychia. Uh,
Sorry, just now general. What do you say? General.
General done on
Like I said, then.
color, cachexid looking.
Uh,
Um, Maybe like fatigue. For example, we can assess the gait,
okay, okay.
slow movement.
The one is by the first time patient step in. Okay.
Okay. Then we can proceed with vitals lah, doctor.
Okay, by the sign very important.
Yeah. Like tachycardia,
Okay, pulse. Okay, pulse.
pulse volume.
Tachycardia.
Yeah, pulse volume, tachycardic.
Tachycardia. Why you want to look for tachycardia?
Signs of blood loss. If patient is having tiredness due to anemia secondary to blood loss.
Okay, good.
Okay. If bradycardia could be thyroid problem,
What type of thyroid problem?
hypothyroid.
Yeah, good.
Uh, Not to forget, just now I forgot to mention jaundice also, doctor, because
Okay, jaundice in general.
jaundice lah.
Why jaundice?
Hemolytic anemia, doctor.
Yeah, one of it is hemolytic anemia.
Hmm.
It could due to any other thing. Jaundice.
And then we go back to the vital sign, hypotension, blood loss,
Okay, blood pressure lah. Okay.
and then respiratory rate.
Okay.
Okay.
Vital sign you should check. Very important.
Okay.
Okay.
What else? It's in general. Then we can, yeah, SpO2, weight,
Oxygen level. Now we can assess it easily.
and then we can proceed with the systemic examination.
Okay. Let me leave the chance to other your friend. Okay.
Okay.
Thank you. Thank you. Very good. Okay. Oh no, Faham name again. Colonychia. What is colonychia?
Koilonychia is pulling of the nail shape.
Okay. It's related to what disease?
Koilonychia. Nutritional deficiency, iron deficiency.
Yeah, iron deficiency particularly. Yeah. Good. Okay. Go further. Now it's already in phase. Let me check. Okay. Kumota, you again. Microglossia. Hi, Kumota.
Hi, Prof. Macroglossia because of megaloblastic anemia, like folate and vitamin B12.
Okay. But if B12, I have different opinion. B12,
Yes,
which
Prof.
type of tongue changes could be B12? Instead of become bigger, the tongue will change in what shape?
I'm not
Red.
sure, Prof. Sorry.
Okay. Nuru Huda has answered. Red, yes. And also, Nuru?
I'm not really sure, Prof. Beefy, red,
Yeah, red. Yeah, yeah. Leafy red, yes. And it's smaller actually.
This
okay,
one, sorry, this one is meaning the tongue papilla loss, is it?
It's a changes of tongue papillary loss.
Is it
It's like
something
that. Yes, could be lah.
that's
Kind
the
of that.
B12.
Yeah,
Yeah.
it become red. Yes, yes. And it's related to what disease?
Usually it's B12, vitamin B12
Yes, yes,
deficiency,
B12. You're
affecting the
right.
taste buds.
Yes, you're right. Okay, good. It's B12, huh? But in Iskandar Zulkarnain, yes, glossitis. Glossitis is quite a general term now. If glossitis, what can you see in the tongue when you examine the patient? Now we are now in physical examination. You look for the sign. So if glossitis, you look at the tongue. What you see? Iskandar, is it mentioned here, glossitis?
Yes, Prof. Yes, doctor.
Uh, uh,
The tongue appears smooth, shiny, and red lah due to loss
yeah,
of
okay.
papillae.
Not really red, but can be pale.
Like raw looking lah, raw looking.
Yes.
Yeah,
It's smooth, shiny, and a
yeah,
bit bigger. Okay,
yeah.
good, good, good. And then Kartini is mentioned also here. Okay, good. So what other physical examination want to check? Anyone? Okay, we go back just now. Hair thinning, Jyoti. Sorry if I mentioned wrongly your name. Can I
yes,
call you
sir, Prof.
Aravin? Yeah.
Yeah, me.
Hmm. Hair thinning, yes, right. So it's related to what disease?
I think it's iron deficiency,
Yes, one of it.
hypothyroidism.
Yeah, and hair loss also, not only
Yeah.
thinning loss. Okay, you come to hypothyroidism. What other sign you want to look for? Do you mind with the answer?
Hypothyroidism.
Yeah.
Physical examination or the
Now
physical
you are now in
appearance?
physical examination. What a sign you want to look for?
Uh, patient usually looks obese. The
Yeah.
neck
Oh,
swelling.
yeah, swollen, edematous. Okay, good.
Usually their face looks very puffy.
Okay, but you shouldn't describe too much, lah. Yes, you said puffy enough. Some people describe it too extreme. They say it's a cold light. Shouldn't that do so, huh? You
Okay.
say puffiness, good. Okay, edematous. Okay. What else?
Brittle nails.
Yeah.
Usually they slow response.
In terms of
The way they talk, the
the talk,
response.
yeah.
Yeah.
Other than the way they talk slow, there's one important sign you can elicit when they talk. What is that? It's very relevant also.
Uh, Not sure, bro.
Okay, your friend already mentioned hoarse voice.
Hoarseness. Okay.
Yeah, by right, when you introduce yourself, say, "Hi, good morning, I'm Dr. Lu. How are you?" The patient talk to you, very harsh, very hoarse voice, then you know it's possibly hypothyroid. Okay,
Okay.
and also good. Thank you.
Thank you.
And yeah, Chan again, Chan Mayin. Yeah, you mentioned about relay reflex.
Yes,
Good.
doctor.
So what we call that the reflex?
Sorry, I forgot the word. There is a specific word.
Hung up. A bit delay hung up. Okay. And usually where you want to check the reflex, which part is more important?
Usually
More.
is the knee reflex.
Mm-hmm. Yeah, ankle reflex. Okay. You can particularly check the ankle. Okay. And in fact, reflex is the best way for you to differentiate whether this patient has hyperthyroid or hypothyroid from physical examination, other than the weight. Okay. Actually, you can practice this in your clinic. Other than you check the weight for patient, whether a patient is become hypo or hyper, you can do the deflex. Okay. And Kumota, this is common question we arise. You mentioned about pre-tibia myxedema, right?
Yes, Prof.
Is it more common in hyperthyroid or hypothyroid?
Hyper, I think. Hyperthyroid.
Yeah. So the word of myxedema here is means normal. Myxedema actually means hypothyroid, but pre-tibia myxedema actually happen more common in hyperthyroid, especially Graves' disease. Okay, so make
Yes,
this.
Prof.
Okay.
Thank you.
Good. Okay. Go back to the examination. We have still a lot to examine. What else you want to examine? You come down from the face, go down. What other thing you want to examine in physical examination? Yeah, goiter, yes. If no goiter, what you want to examine in the neck? Yeah, lymph node, okay. I mean, if patient have hypothyroid, no goiter, what you want to look for in the neck? Okay, breathe, okay, breathe to rock, possible carotid breathe or anything. Lymph node by right is supposed to be in general examination. Size consistency when you have goiter, but you don't have. Patient come with hypothyroid, no goiter. What else you want to check? But in fact, that one you can get from the history lah. JVP is for what? Not thyroid, right? Kumuta? Heart failure, yeah. We go to that later. You want to check for scar lah. Okay? Any scar, thyroidectomy scar, okay? Don't try to look for it also. Okay, we come further down. Heart failure. What other sign you want to elicit in heart failure? Murmur. Okay. Byvasal crepitation, PD edema, yes. Okay. What else? Gallop is severe heart failure lah. Okay. Gallop rhythm is actually not normal, you know. It's okay. Displace apex speed. Okay, we go back to murmur. Nurul Huda.
Yes, doctor.
Murmur. Why murmur?
Mama, because secondary to anemia.
Yeah, severe anemia lah, basically,
Yes.
Functional murmur actually. Okay. But in heart failure, actually, what we call fourth heart sound, gallop rhythm is not murmur. It's different a bit.
Yes, doctor.
Only medical student can elicit that lah.
Yeah.
Oh, doctor. Okay.
All right.
It's in the book, right? Medical student can elicit.
Yes, doctor.
Okay. Okay. Now we go further. Gayatri. Okay. Hepatomegaly. Good. Now we come to abdomen already. Other than hepatomegaly, what you want to examine in abdomen? Spleen, yes. Mass, yes. Ascites. Okay. Pulsation of what? Indru case? Sorry. Indru? Pulsation? What do you mean by pulsation? Oh, okay. A. Triple A lah. Okay lah. But triple A certain people come in with tiredness, right? It's very difficult to detect also lah. Okay. Anything else you want to do to complete your examination? Corrector, okay, very fast, Yong, okay. Corrector examination for any NMS. Yong Ji Cheng, okay. Good. Corrector examination. What else, other than to look for NMS? Yong, are you around?
Sorry, Prof. Yeah, yes. So just now
Uh,
you mentioned other than NMS, I can look through PR. Then I can do PR to look for any PR bleeding or malignancy too.
yeah, that's more relevant in this case lah. I mean, of course, NMS, yes, but
Okay.
usually colorectal cancer, which part is more common? So sorry, I cross over
Rectal
to
sigmoid. Rectal
pardon?
sigmoid.
Yes, rectal is more common, right? Anal is less lah. Okay, so maybe you need to do deeper examination. Quite difficult also. Okay, genital, yes. Kumuta, genital.
Hi, Prof. Janitor, because want to rule out cervical malignancy, all that.
What you
Kan,
want
so
to
want to
do?
look for ni per speculum. So we see for any
Yeah,
abnormal group.
yeah. Good. So breast examination number, it depends on the history also lah, huh? Okay, good. So look at the slides. Oh, I cover most of it. This is a physical examination you want to look for. But I want to remind you all, for physical examination for hematological system, you need to remember that our blood have three components. Our bloodstream has three components: red blood cell, white blood cell, and platelets. Okay. If you examine throughout these three cell line, you can make your examination more complete. So for red blood cell, you check for platelet. Okay, jaundice, okay, good. White blood cell, you check for lymph node. So always do not forget lymph node. Okay. And for platelet, any bleeding tendency lah, other than the mucosa bleeding, corrector, okay, is it bleeding? Yes, bruises also need to check for skin, okay. So remember that, okay. And in hematological system, do not forget liver and spleen, okay, because it's reticular endothelial system, so it's related to hematological system, okay. Remember that. Now, so after doing the history taking and physical examination, so what differential diagnosis do you have in your mind? By right, you should have this right from the beginning. Actually, Kumota is already starting with all this. So can you just summarize, anyone? I mean, just repeat whatever you discussed. Anyone?
Thyroid,
Yeah, hypothyroid, right? Yeah.
hypothyroid, any malignancies,
Yeah, malignancy.
um, and she has any other blood complications such as thalassemia.
Yeah, anemia lah. Okay. What else? Tiredness.
Uh, IDA, malignancy,
Anemia.
any psychological such as
Yeah. Particularly.
depression.
Yes. Okay.
Is she, because 40 years old, is she having any heart failure or any disease such as
Okay.
diabetes or and this one? And
What we
also
call that? What do you call
uh,
that?
underlying
Diabetes,
diseases,
hypertension.
underlying
Yeah,
NCD diseases, non-communicable disease,
yeah. Actually, chronic disease lah, huh?
chronic disease.
Disease.
Yeah.
Yeah. I think yes, good.
Or any nutritional deficiencies.
Okay, good. They will contribute to anemia lah, huh?
Yeah.
Talking about this. So these are the things. Prof who particularly want to emphasize on drug-induced ulcer and said lah, which is very
NSAID.
common. Okay.
Yeah.
Okay, good. Now, what investigation would you order? I mean the primary care setting. Full blood count, yes, good. Thyroid function test, urine iron study. Okay, we common one first. Yeah, full blood picture. Okay. Full blood count, peripheral button, common one first lah. And the rest of the investigation, it depends on the history and physical examination also. Okay. Now go to investigation. This is a full blood count of the patient. Interpret the full blood count.
Prof, can I just try?
Yeah, good. Can.
All right. Hemoglobin is low, so we know there is a component of reduce in hemoglobin. So we see the MCV and MCH both shows on the lower side, which is more of hypochromic microcytic anemia. Platelet
Yeah.
is normal, and while the white blood cell is also normal in is still
Yeah.
between range. Yeah.
Okay. So you mentioned about microcytic. Which of the component here indicate microcytic?
MCV,
Yes. Okay. Hypochromic?
MCH.
Okay. MCHC and MCH. Which one is more accurate?
Usually it's MCHC is more accurate.
Yeah. Okay. MCHC is actually more accurate because it's concentration of the
Yeah.
MC. Okay. It measure the mean corpuscular hemoglobin in one certain volume. Okay. Meaning that even your blood is diluted, also it can be more accurate. Okay. Good.
Thank you.
Okay. Good. So another question. What are the differential diagnosis for microcytic hypochromic anemia?
Possible of any hemoglobinopathies or thalassemia.
Okay, thalassemia first. Okay,
Yeah.
common one other than thalassemia. Iron deficiency anemia. Yes. Okay.
Iron deficiency. Okay.
Okay. Good. Okay. So thalassemia. What we're talking about here is thalassemia major or minor?
Thalassemia minor. Carrier.
Yeah. If major, will it be the same?
They were usually presented at early age.
Yes.
Already need blood transfusion.
Yes. Very good. Up to 40-year-old. Already multiple transfusion. Then the full blood count will be different. Okay. Okay. Now, question is how you can differentiate these two. Iron deficiency anemia and thalassemia trait. How to differentiate? I mean, from full blood count itself first. Okay, Kumuta later. Later.
Dr. Lu,
They usually measure
measure
sorry,
index.
I will count measure index.
Okay, good.
Less
So,
than
who want to
30
answer? Looks like
is
so many of you.
thalassemia.
Okay, one by one. Munira, I saw you. You want to answer?
Okay, from the FBC component, I will calculate the measure index. So less than 30 is suggestive thalassemia. More than 30 is looks like IDA.
Okay.
And then, yeah.
You know the formula?
MCV over RBC.
Okay, good. Okay, Tan, that's why I saw you want to answer. Tan Chi Hao.
Yeah, hi doctor. Yeah, I'm answering mental index also
Oh,
for the
okay.
differential. Yeah.
Okay. Same thing,
Yeah.
Any different opinion? No, Okay.
No. Yeah.
Okay. How about any other test or any other index you can indicator.
Morning, doctor.
Hi,
Doctor,
Hong.
I would like to proceed with the hemoglobin electrophoresis test to
Okay.
differentiate the thalassemia.
Which type of thalassemia?
Beta. I think it's beta.
Okay, good. But that one is later lah. That one is definitive. But now I want you to be a bit smarter. From full blood count itself,
Oh,
you
I
can
see. Okay.
suggest
Right.
which one is more favor which one. Okay. So other than mental index, there's another way you can predict lah which one is more possible. Anyone But usually you know about mental index, you know about another indicator.
Is it, hi doctor, maybe we can look the MCV and MCHC in thalassemia, the count will be like, not like this one, much more reduced as compared to IDA.
Very difficult to do so also.
Oh,
There's another way to do it. I mean, for the full blood count, MCH is not in. MCH is not in. It's another way. Yeah, no Fahaminim, RDW. What is
Yeah,
RDW?
it's red cell distribution width,
Okay,
but I couldn't remember the value actually taught by my doctor during HO.
okay. Value is not important here because you always have normal value in your result, right? And different lab have different range of normal value. But this one, just need to know higher or normal only.
Yeah.
Anyone? Yes, it's red cell distribution width. Okay, correct. It's normal suspected thalassemia. Neurofatin. Yeah, also, okay. So what is red cell distribution width? Okay, you can always Google it lah. I let you know about this method lah. Actually, all the football count you have this RDW. You try to study it when you look at the patient's result. Okay, but this is not definitive. This is suggestive. Okay, so red cell distribution width is measure the average RBC size variation. Okay, meaning RBC got different size. The greater the variation, the higher the RDW, and it happened in iron deficiency anemia. Okay, now these are the two methods you can differentiate. Okay, iron deficiency anemia from thalassemia trait. Now we go to peripheral blood film. That's how Kumuta mentioned. So how do you differentiate these two? By using peripheral blood film. RBC shade, yes. Okay, cell one, good. Pencil cell, which one is more common? Pencil cell.
Usually for pencil cell is more towards IDA and target cell more towards thalassemia.
Yeah, good. So you know about this. Good. So what is the normal shape of red blood cell?
Biconcave,
Yes. Biconcave what?
round, round biconcave.
Round now as a
Yeah.
disc, like, okay.
Yeah.
Like, good. So we go to the peripheral blood film, okay? So I will show you lah. Iron deficiency anemia, look at the slide, will have microcytic hypochromic, just like full blood count, okay? Anemia, okay? And you can see N-isocytosis and point kilocytosis here. What is N-cytocytosis? N-isocytosis, sorry.
It is actually different shapes and also different sizes.
Okay, which one is different size?
I think I say Aniko is a different shape.
poikilocytosis
kilo
different
is
shape.
different shape. Different size.
And isocytosis. Cyto is a size lah. N is different. Iso is same. N iso is different. Okay? Different in the size lah. N cytocytosis. Poikilocytosis is different in the shape. Okay? So the shape, normal shape is biconcave this, right? So it become different. How different it become? It become like a pencil cell lah. Okay? So different in the shape. In iron deficiency, instead of a round, it become pencil, which is elongated. Okay? This is a change in the shape. And one clue in iron deficiency is that patient has reticulocytopenia. Okay? Reticulocyte is actually a middle product of RBC. Okay? We use analogy as bone marrow as a factory. Okay? And the raw material is iron, end product is RBC, and reticulocyte is middle product. So when the factory has reduced raw material, the production also reduce, and the whole production line also reduce lah. So the reticulocyte reduce, the end product RBC also reduce. So it's indicate a underproduction anemia. Okay. Whereas in bleeding hemolytic anemia, what will happen? The reticulocyte will increase, right? You all remember that day the Prof. Go's case, spherocytosis, the one? Osmolytic fragility test one. So the reticulocyte will be increased because of the raw material enough, but lost a lot at the end product. So the factory produce more. So the reticulocyte will be increased lah, the middle product. Okay? So iron deficiency anemia is underproduction anemia. So reticulocyte will be reduced. Okay? It won't happen in thalassemia. Okay? Okay, now thalassemia, same thing. We have microcytic hypochromic and isocytosis, poikilocytosis. Same thing. Only the poikilocytosis here is different than the shape of target cells. Target cell is a round shape in the dot in the middle. Okay. Also, a feature of basophilic stippling. This is the pathology observation. It is examined under microscope when the pathologist put some alkaline stain. Base is alkaline, acid alkaline, acid base. Okay, base is alkaline. You put the alkaline stain to the slide, then you can see the red blood cell have multiple blue color dot. I will show you the picture later. Then this happen commonly in thalassemia. Okay. And the last one, nucleated RBC happen in the thalassemia major. So I don't mention about that lah. Homozygous is major. Okay. So now we go to see the slide. Okay, this one left upper is normal lah. Biconcave this. Okay. Smaller size, microcytic. Reduce color, hyperchromic. Okay, reduce color. Then this is reticulocyte. Okay. And this one is target cell. Yes, round, not in the middle. And this is electrocytes, actually pencil cell. And some people call it cigar cell. Okay. And this one, the blue color dot is basophilic stippling. Okay, it's like this. Okay. And one more thing is that sickle cell, there one case about sickle cell, right? Still remember? Patient with priapism, sickle cell is look like sickle. Okay. Now in summary, to differentiate iron deficiency anemia and thalassemia, you use full blood count to look for RDW and Menzel index lah. RBC is for Menzel index. Okay. Iron deficiency anemia, RDW will be high. Menzel index will be more than 13 lah. Because Menzel index MCV over RBC. So this is low, then the equation became bigger lah, more than 13. Okay. So useful this one. The definitive test is iron study for NPC anemia, and HP analysis is for beta thalassemia. I think Hong mentioned just now. Okay. Microcytic anemia. This algorithm you can find it from Google lah. Microcytic anemia, RDW first. If more than normal, not necessarily 15, more than normal, you suspect iron deficiency anemia, you do a ferritin level. If low, is iron deficiency anemia. Okay. Let's say patient has microcytic anemia, you do RDW, okay, is normal. You do HP electrophoresis, is normal. So what you want to do? Okay, DNA analysis. So you suspect what? Alpha, yes, thalassemia. Okay. So I think we cover, this is the last slide for hematology. Okay. So you can take snapshot this one. So usually I will remember the last column on the right side. NAPC anemia, ferritin low, TIBC high, RW elevated, Menzel more than 13, HP electrophoresis normal. Okay.
Excuse me, Dr. Lu. Is it possible that are you willing to share the slide with us?
Cannot. This one is a copyright of academy.
Okay, thank you.
And most of the part of the slide is created by Prof. Ku. Okay. I added something only lah, some video. Okay. The main idea is for you to understand how you go about. But all this information nowadays you can easily find from internet lah. You get a lot of ChatGPT, everything. But only thing is for you to know which one is correct lah. So you need to know how to analyze, how to look at the result or slides and apply it in your practice. Okay. Don't worry so much about the information. The interest is more important. Okay. Any question? Last question for hematology before we go to oncology. Okay, no, so we go to oncology first, then half oncology we take a break. Okay. Oncology, we are not going to discuss about tumor, cancer, chemotherapy. We do this role play, communication skills. Okay. And this one actually we have argument. It's quite difficult to do online. Some lecturers say it can be done, but Prof. Fu and I may not agree lah. We find it physical meeting is better for this. But in view of online, we still try to suit your to do it lah. What my method is not to do communication like role play online. We think it's quite difficult. So I will show you a video. Okay. Then you imagine as if you were the doctor in a video. And after that, we discuss whether the doctor is doing correct or not okay. Then we comment. Okay. So breaking barriers is the bread and butter of communication skill. You should master it. Okay. So I give a scenario. The scenario is like this. When the video, I took it from YouTube. So it's tertiary setting lah. Sorry, I can't find a primary setting one, but the concept of communication is the same lah. So you order CBC, this American one, complete blood count, comprehensive metabolic panel, mammogram and breast biopsy for Madame Forrest. The result confirms invasive breast cancer. She comes for the result today. Proceed with the consultation. Okay. Now we go for the video. Can you all see the video? Okay.
Hello, ma'am. Miss Flores?
Yes.
So, what's your body been telling you?
Well, I get very tired. I get some dizziness when I get overly tired. I have a lump. I'm scared. I want to know what the results of the test were.
Well, the reason we've been doing these tests, the CBC, the comprehensive metabolic panel, the mammogram, let's get right down to it. Mrs. Flores, you have invasive breast cancer. It's metastatic to your lymph nodes. It's estrogen receptor positive, which is a good thing because you will respond to hormonal therapy.
What? I can't have cancer. No one in my family has cancer. Are you sure?
The next step will be for me to send you or for you to meet with a medical oncology team and a general surgery. They will probably recommend a mastectomy, a lumpectomy, and this will be followed by radiation therapy and chemotherapy. Do you have any questions? Have I gone too fast?
Oh, I didn't understand. All I heard was breast cancer.
Yes, sorry. You have a tumor, a growth. It's serious in that it can spread and it can grow pretty quickly. So it's been very insidious. Any more questions?
How can I have breast cancer? I kept all my mammogram schedule. I kept my checkups.
So your cancer has been very insidious. Was undetectable at stage 1, and breast cancer is very prevalent in the Hispanic population. You know what I need for you to do is just to remain strong.
I have breast cancer.
Yes, I know. That's the way nature is. I think I'm just going to refer to the medical oncology team at this point. But you know, Mrs. Flores, I know you can bounce right back from this. You're very active.
Am I dying?
No, you're not dying. You have plenty of treatment options available. In fact, I'm sending you to the best medical oncologist in town. I guarantee you're going to be fine.
I'm scared, doctor.
You're going to be fine. There's plenty of cancer survivors everywhere. In fact, my Aunt Marie, she was diagnosed with breast cancer and she is doing fine.
I don't want to be in pain like my husband was.
Like I said, you're going to be all right. I know just how you feel.
I've seen what cancer can do to you. It eats you up. My husband died of colon cancer.
So you know what the harsh treatments that are going to arise and the issues. I'm available to help you. Why don't I set up a meeting with you in a couple of months, say 6 months?
Breast cancer.
I'm sorry, yes. I'm going to call in my nurse practitioner, Bonnie, and she'll be available to answer any questions. You can take your time. Here's some tissue if you need some. Let me go call her now. Here. Okay? I'll see you in a couple months. Bonnie.
Okay. So anyone want to comment?
Hi, Dr. Tan here.
Okay, hi.
First of all, I think the doctor should be sitting at the same eye level with the patient first, and then starting
Okay.
with self-introduction.
Okay, good. Why Why you want to sit at the same level?
Is uh, a better or comfortable position with the patient instead of
Comfort.
sitting higher than the patient, and patient need to tilt the head out and looking at us when
There's
we
one,
explaining.
there's one reason, but more relevant
Mm.
one. Very important actually, this one.
Eye contact.
Yes, you need eye contact. Why you need eye contact? A proper eye contact, I mean, 10 level. Why?
Build the rapport, and
Yes,
then
yes, to build a rapport. So the communication skill, the first thing you want to do is to build a
uh,
rapport,
yeah,
right?
yeah.
Before you want to talk. Okay.
Okay.
And any further things to talk about this case? I think you have a lot of opinion, huh? Many of you should have a lot of opinion. So yes, good. Eye contact. What else? Same level. Yes.
And then also any family members around and call
Okay.
in.
Yes. That one before that, huh? Yes. Before you start anything.
Yeah. And also the phone. She
Okay.
doesn't mute the phone.
Yes. Why you want to mute the phone?
To show patient respect and full concentration in the conversation, not interrupted.
Yes. That's one way of building the rapport
Rapport.
also. Yes. Show respect, building rapport. Okay. Okay. What else?
Empathy.
Yes, empathy. So overall, what do you think about this case? Is she empathy?
No.
Prof could always say this is actually heartless lah, this
Yeah.
doctor. Okay, right. Can we say
Mm.
so? Okay.
Yeah.
Any other comment? I think a lot of things you can comment here, right?
Need to explore her feeling and also understanding regarding the current medical condition.
Yes. You need to explore first, right?
Mm.
She go right to the point, right?
Mm.
Yes. So you should explore. Why you want to explore also? Why you want to explore?
Um, to know her feeling and also understanding towards her illness.
Yes. So the idea, concern, expectation also. There's one way to build the rapport also. Right? So anything else? Or you pass to your friend?
Okay.
I think they all have a lot of opinion also. Okay? Okay,
Okay.
thanks.
Thank you.
Done. Okay. Uh, who else? Okay, Chan Mei, yes. You say showing dominant. Good. So how did the doctor show the dominant here?
She is sitting at higher level compared to
Yeah.
patient.
Yeah.
And she does not address patient's concern as well.
Okay. What concern did the patient have?
Patient was afraid if she will die,
Okay.
the effect of cancer towards her.
Yes. Okay. So you should pick up the cue and address right away lah. Oh. Okay. Showing dominant, is that a good way to build rapport?
No.
No. Oh. Actually, in communication, actually it's a two-way dynamic. So you should be same level. Always remember. It's high up, then it's difficult to communicate. Okay. Okay, Siti Amira. Yes, you have a good point here. Leave patient just the moment she started to cry. Okay, can you elaborate more on that?
Yes, Prof. Because actually she just brushed off the concern of the patient. Patients keep on saying, am I gonna die? Is it gonna be painful? And then when the moment she started to cry, the doctor just said, it's okay, I'm gonna refer you to another nurses that can soothe your concern like that. So she did pass the tissue, but she actually do not show good empathy to the patient.
Yeah, correct. So you should, if you were the doctor, how are you going to do?
If I were the doctor, well, the first thing is I'm gonna sit in front of the patient, see eye level, and then at least pat on her back, and just like her, I know I can understand you. Just say the good things to her lah, at least to soothe her a bit.
Yeah.
Mm.
And the timing of offering the tissue, do you think is correct?
I think the tissue should be passed to her a bit earlier on.
Yes,
the
right.
moment she dropped the bomb lah.
Yeah, the moment patient cry, you offer the tissue straight. You have
Yeah.
tissue with you, right? Correct. Okay. Anything else? Okay. Patient's concern, interruption. Okay, Kumuta again. Medical jargons. Yes. So what is medical jargons?
Hi, Prof. She mentioned invasive breast carcinoma. Yeah. So there are many terms that she mentioned whereby it can be used in a layman term so that patient can understand better.
Okay. So basically, jargon is technical terms that cannot be understood by the lay person. Okay. And the jargons here, what are jargons other than the invasive breast biopsy? What else?
Staging of the cancer.
Beg your pardon, Hidayah?
She also said that stage 1 very early.
Yeah. Okay.
So
Good.
what is the stage 1?
Yeah. In fact, also CBC. Yeah. CBC is abbreviation. It couldn't be understood by other people also. But okay, if you you are forced to use medical jargon in some conditions, what can you handle it in a conversation? How can you handle it?
Brand use pictures so that they can understand.
Yes, what's one way? How about let's say it's breast biopsy? So or patient need to go to see a to handle it because you are forced to use the jargon, right?
Prof, we just explain what is the procedure about what that means in a layman.
Okay, correct. If you accidentally mention about jargons, don't worry. You just I refer you to an oncologist, which is a specialist in cancer. Okay, you explain it. Then you are all right. Okay. The concept here is to make sure the patient understand what you are talking about. Okay. Okay, good. Malati, you mentioned about over-promising about prognosis. Okay, what do you mean by that? Hi, Malati, are you around?
She's having trouble with her mic.
Okay, it's okay. There anyone?
In the video, she mentioned about the prognosis of the disease is good. There are people that she knows currently doing well, even diagnosed with cancer. So I think it's always based on patient and it differs for each and every patient. The outcome will be different. So when she said it can be cured, it is nothing. So it's all promising, doctor.
Do you think that one is correct?
it's not, doctor, because she still need further investigation. What are the mood of treatment and how she responds. So all this comes together to see the outcome of her outcome of her outcome of a treatment and prognosis of the disease.
Okay, okay. So in other words, actually, she's giving unrealistic hope, right? And in any communication, you must be honest and must be realistic, okay? Otherwise, you get into trouble. If you get unrealistic hope later, you may get into trouble, okay? So be honest throughout the conversation, okay? Okay, Kitana. Kitana, are you around?
Yes, doctor.
You mentioned that she was rushing to give information.
Yeah.
Okay. If you were the doctor, what would you do?
So, first of all, I will listen to her first. What is she expecting? And rather than pausing in between, but she actually rushed through the information. She never ensured that if the patient understands whatever she's saying. That was the one actually. And breaking bad news that time, and she didn't give her the chance, the warning before she said the
Okay.
word.
Yeah, I heard something warning. That's very important.
Mm.
So what we call that? A warning.
Not sure.
Not sure. Anybody? That's one of the important technique in breaking bad news. Yeah, you mentioned about warning. So what we call that? Priming, yes. So there's one term for it. Eugene, priming. Eugene, are you around? So let's say I give you a scenario lah. In this case, actually, do you think patient come with expectation to have a breast cancer? Do you think patient expected her to have breast cancer when she come for the consultation?
No, I don't think so, because when she received uh, the diagnosis, she's appeared to be in shock.
Yes. So the expectation is normal, but the reality is cancer, right? So there's a way to prepare the patient. Okay. So no Fahamin already mentioned is what we call warning shot. Okay. You prepare the patient first. So no Fahamin, okay, obviously you are.
Yes,
So if you were the doctor, you want to give a warning shot, can you try? Give an example.
So, Madam Forrest, as we know that you have done some biopsy for your breast, unfortunately, that the result today were not as what we expected.
Okay. Then you'll stop for a while. Okay? That's one way of warning shot. Even though you can go straight say, Madam Flores, I'm afraid I have a bad news for you today. Then pause. The warning shot, the purpose is to let the patient prepare whether she want to continue the conversation or not. Sometimes the patient may say, "Oh, I don't think I can. I'm not ready yet. My husband already passed away. My family not around. I want to come with my sister, maybe in the next appointment. Then that time only I want to know. If that is the case, it's okay. Just stop at the point. But if the patient asks, then you can give the full diagnosis. Okay, that is a way to prepare the patient. So the impact of the bad news is not so intense in the words. Okay, and because the patient gets shocked, right? So you want to reduce the impact. Okay, so Kumata, yes, you can use the spikes mnemonic. Okay, anything else before we go for the proper way to break the bad news? Okay, yes, Kumuta, you're right. Commonly, you can find from internet is the stepwise approach. So clinical skill is just like communication skill is just like clinical skill. You have some stepwise approach. Okay. Common one is what we call spikes. Same for setting, perception, invitation, knowledge, empathy, and also okay, summary lah. Okay. Okay. That's a common way. You can Google it, and for usual practice, you can use this approach to try to practice lah. Like clinical skill, you need to practice as much as possible to show to master it. Okay. Myself, I'm a bit lazy lah. I try to have my own acronym, the stepwise approach, which is we call PSCS. Okay, I share with you. So the simple one is P is stand for prepare and purpose of meeting. A, you need to assess, address the concern. Okay. C, only you counsel. S, strategy and support. Okay. I use this acronym because I want to remind myself that A, assessment, is always before C. In all the communication, you need to assess the patient's idea, concern, expectation first before you counsel the patient. Don't go straight to point to counsel. Then you'll miss a lot of things. Okay. So we go back to Prof. Khoo's slide. She has prepared some stepwise approach. We go through it quickly. Look at the slide. Okay, first you need to prepare the patient. Okay, and unlike in this situation, you need to prepare the patient in a quiet environment, comfortable, away from any interruption. Switch off your pages, your cell phones. Okay, and tell your nurse that we have important meeting. Okay, try not to interrupt if possible. And you need to prepare it's a sitting position. Okay, and just now it's a bit high up, right? You need to prepare at the same level, eye contact. Okay, mentioned already. And you need to prepare yourself also in real situation. What you want to prepare? So you must make sure you know the report, the result is belong to the right patient. Do not break the bad news to the wrong patient. Then it will be bad news for you. Okay? Make sure that's important. And you need to prepare the patient. So how to prepare? Then you tell the purpose of the meeting. Madam Forrest, the purpose of meeting today is to review all your investigation results. Okay? We have done 1 week or 2 weeks ago. Okay? And now we go to assessment. Myself is assessment. So it's more information wanted. So you ask her about so far how much you know about what has been done. Okay. And assess her idea, her expectation, particularly. Concern not much here before you break the bad news, but expectation is very important. So she expect her result to be normal, right? But you don't ask her, what do you expect? You can have chit chat with her and you roughly know that's her expectation. Okay. And in the preparation also, you can ask like one of your friends say, do you come with your family member? Okay. That's a way of preparation of patient, prepare the patient. Okay. So it indirectly tell the patient some important things we need to discuss. So better to have family member around lah. Okay. And you need to break the bad news using warning shot we mentioned just now. And after warning shot, you deliver the diagnosis, the bad news, you pause for a while, stop. I think one of you had mentioned, stop for a while. Then let her patient to have emotional, ventilate the emotion. one of it is denial, Prof. Hu say. Other than denial, what other stages of grief or stages of emotion that patient would have? Anyone? When you get the bad news, what emotional changes or emotional stages you may have? Yes, anger, sad. Okay. What else? Doubt. Doubt. Okay. What else? Disbelief. Actually, there are some formal one. Fear, yes. Fear is one of it. Bargaining, yes. What else? Denial, yes, definitely. Denial will have more. Actually, commonly they will have denial. Depressed, okay, yes. And acceptance. You can Google for the stages of grief. Okay. Acceptance, done if acceptance is good for you lah. If patient go to acceptance rate, then your consultation will be easier. Okay. Also shock lah. One of it is shock. That's how we mentioned. Shock, denial, bargaining, anger, depressed, and acceptance. Okay. All these stages may not come in sequence. It may come one shot or it may come slowly. Okay. So you wait for a while, allow them to have denial or emotional. Okay. Pause for a while lah. If patient cry, offer tissue in the right time. And you can tap on the shoulder, but okay, depending on how close you are with the patient now. I myself don't really think tapping on the shoulder is necessary, but proofing is okay if you are close with the patient. Okay. And when patient have, after the emotional stages, patient may have a lot of question to ask you. When they ask you the question, it's time for you to explain. Okay. Do not give any information, bombard her with all the medical jargons during the emotional stages. Okay. It won't go in. Patient won't listen to you. Okay. Wait until patient to ask you question, then only you answer. But make sure you answer and pick up the cue. Okay. And when you give information, do not give unrealistic hope, like in this patient. And also, do not compare. Okay, do you know that she actually compare with her auntie, right? Every patient is different. So just focus on the patient also. Even though your patient is a doctor or even a professor, it's still your patient. And do not compare. Don't say your doctor, you must know everything, you must be strong. But every patient is different. You take them as individual, okay? And also, lastly, you can always support the patient, but try not to give unrealistic hope lah. You try support the patient that you're going to refer her to a doctor, the specialist in this field immediately. You can say immediately. You can do it right after that. And you can actually ask her to come back if any question. Even though she already follow up with the breast surgeon, you can always come back to us and offer availability lah. You can offer phone number. Whether you want to give personal number is up to you. But we prefer to give the clinic number lah. Okay. I think that's all. And be empathy throughout the conversation. And remember, we are bound to ethics. When we give any communication or consultation, we are bound to ethics, medical ethics. So what are the medical ethics do you know of? Meaning the ethical principle. This one is important. But in this case, may not have a lot of medical ethics involved. Yes, beneficent, non-malefficient. Non-malefficient. Malefficient is not good. Non-malefficient. Okay. What else? Autonomy, yes. One more. One more. Justice. Okay, yes, good. So this one is useful for the next case. So far for breaking bad news, any question before we go for a break? No question for Kumota. And the rest of you, any question? Okay, so we go for a break for 15 minutes. We come back at 10:45. Okay?